So with that in mind, and we understood that joint attention was problematic for young children with autism. It's not that they didn't do it at all. They just did it very, very less. We started to conceptualize autism in terms of a model where the infant does a little of this kind of social attention called joint attention. Their learning environment is less organized or not as optimal as a consequence, and that goes on to have a cascading effect. They take in less critical information at critical times, so they have less cognitive development, less social learning going on. You allow that to go on for years and years, and you probably start to get some disturbance in actually the structures of the brain that are waiting for this information to come in. And that used to happen to kids with autism. We used to do nothing to make the diagnosis, and the child really had no treatment, so we didn't try to intervene with this part of the disorder. That's changed tremendously. We were talking at dinner last night. I want to make this point. So I'm talking about an attention disturbance being kind of critical to autism. Well, but we also think about ADHD. There's attention disturbance in ADHD, right? This is different from that attention disturbance, quite different from that attention disturbance. And here's how. The driver with ADHD will be going down the road and see those people looking up. They're going to be equally likely to look. The ADHD doesn't prevent them from responding to the compelling nature of other people's attention. They respond just like everybody else. The driver with autism is going to be less accident prone at that moment in time because they're not going to look. However, if we change it up a little bit and we say, okay, here's 50 dinosaurs. I want you to sort these by epochs when they were alive on Earth. The child with autism is really going to pay attention to that. The child with ADHD is going to pay attention for a little time, look away, and forget even what the task is and start moving around. That's the difference. One is distractibility and short-term working memory, and the other is having something that drives you to attend to what other people think is interesting. We don't know what that is very well, but that's autism. Distractible with poor working memory, that's ADHD. Something else interesting about autism, when we look at things with other people, no, not autism, joint attention. When we look at things with other people, we process them more deeply than when we look at things without looking at other people. This has been shown in adults. There's a great study in infants. So these are 9-month-old infants, and they come in and they have to study pictures, and then you can measure if they remember them using recognition memory. Okay? In one condition, they study the pictures, and the mom looks at the infant, then looks at the picture, looks at the infant, then looks in the picture. So the mom kind of follows the attention of the infant, engages in joint attention. In the other condition, the mom comes in and just looks at the picture. She doesn't look back and forth to her baby. In this study, it's a great study by Tricia Striano, babies in this condition remembered many more pictures than in this condition. And you can see they're wearing EEG caps, measures microvolt electrical activity of the brain. What they saw was the brain activity in this condition was very consistent with deeper information processing than in this condition. So they had both a behavioral measure of enhanced cognitive performance and an EEG measure of enhanced cognitive performance. Just engaging, looking at something with somebody else triggers a different style of information processing in many people. Now, I should say this is based on maybe 4 to 5 studies. 4 studies in infants, 1 in adults. We still have to know more about them, but they're all consistently pointing in that direction. So when does joint attention begin to develop? Another problem that we had in the science was, we found that joint attention was disturbed, and everybody said, oh, yeah, but that doesn't happen until the 2nd year of life. That's really late, 2nd year. And people thought that joint attention really didn't develop until about 15 months of life. And so people were constantly saying, well, that's important, but it's not at the beginning of the disorder. Well, increasingly, we're understanding that joint attention starts to develop in the 2nd to 4th month of life. At least that ability to follow gaze does. And the work that I've done is some of the largest samples following infants. And we're pretty clear now that at 9 months, IJA, initiating joint attention, is stable individual differences. We looked at 115 babies at 9 months. No baby showed less than 5 episodes of initiating joint attention in a 20-minute period. When we've used those same measures with children with autism, they show something like 2 to 8. So many, many fewer. So we're pretty sure this is developing in the 6 to 9 month period. One thing that we also know about joint attention is that it requires a lot of different brain areas working together to function correctly. So these are data from a couple studies. There's now 4 studies with adults looking at different components of joint attention. And basically you get this really strong, very anterior frontal component. You get what's called a medial frontal component, and then you get a parietal component. That's important for several reasons. First of all, that is basically mapping onto the anterior and posterior attention system. So joint attention is very much part of this attention system. 2, those areas of the brain have been implicated in autism. And 3, the implication is in autism that these particular brain areas are vulnerable to not communicating. They're not connected as well in autism. Now, the other thing that we've learned is that initiating joint attention, that one that we think about as being reflecting motivation to a greater degree, actually activates an area of the brain in this, I can't show it, too small, in the striatum. And the striatum is a sort of subcortical area that's highly linked to motivation. So we see in initiating joint attention, a brain area linked to motivation being activated. In responding to joint attention, we don't see that activation. So it's even clearer that initiating joint attention has a motivation component to it. Somewhat clearer. When can we start measuring brain development in joint attention? 5 months. This is a new study out of the University of London, and this is really neat. Instead of using EEG now, you can put light sensors on people, and the light pierces through the skull and then reflects back from the top cortical layers, and it basically tells you how much blood is flowing in those cortical layers. So with infants, we can use this optical technique to understand whether or not certain brain areas are involved in initiating joint attention. And basically, it's areas of the frontal cortex and the parietal cortex. I thought I had highlighted those for you, but oh, there they are. Those are the areas. Okay. The current diagnosis. So we're not completely sure what's going to happen in DSM-5, but certainly right now, when we talk about the social deficits of children with autism, or the social domain, we've got several different diagnostics. This one is not very good under 5 years of age, obviously, because it's very hard to tell whether a 2-year-old has developmentally appropriate peer relations. But you know, this is the one that came right out of the joint attention literature. A lack of spontaneous seeking to share enjoyment, interests, or achievements by a lack of pointing, showing, and it goes on to say eye contact. So that's initiating joint attention. That phrase is saying the children lack initiating joint attention. Okay, that's how this has emerged. That's the direct link with what I've tried to describe in pictures and words for you. So when we talk about this, we're talking about a really central symptom of autism, and a symptom that may feed back and actually, if left untreated, impair the child's ability to learn, and therefore impair their cognitive development. Okay. Let's talk now about intervention. There's 2 different ways we can intervene. Most often, we go at a rehabilitation model. We say there's so much going wrong for these children that we're going to try to be comprehensive, and we're going to try to rebuild everything. Rebuild the ability to sit, rebuild the ability to talk, rebuild the ability to use a pencil and paper, etc. Those are the comprehensive programs. One of the best known comprehensive program has come out of behavior analysis, so they're now called applied behavior analytic programs. I'm going to talk a little bit about them. But then there's another approach. As we get a deeper and deeper understanding of autism and the central dysfunctions, cognitive or social, we might be able to go in and simply address those particular areas of disturbance. And by doing that, we might be able to, it might take less effort to do that. They might be more efficient. But if we can change that, there might be a cascading effect. So if we could change joint attention really early on, theory is that it would help a child learn in any situation. Okay, so that's an example of a pivotal or targeted approach to behavioral intervention. And so I'm going to talk to you about applied behavior approaches, and then a new line of research that's determining whether a joint attention pivotal intervention can actually augment or boost what happens in applied behavior analysis. And we don't have time to go through the whole history, but if you want to go through the history, we can talk about it in question and answers. But Tris Smith was a student of Ivar Lovaas. And Tris understood the good things and the bad things out of the Lovaas programs. And he's gone on, he's at the University of Rochester now, and he's doing really great work. And so what he's done is what's called a randomized controlled trial. You know, we talk about evidence-based treatments, interventions. Evidence-based is hard to define. It requires a certain criteria of research. Probably the best or the most important type of research is randomized controlled designs, where the experimenter simply says, I'm going to treat a bunch of children, but I'm going to, without knowing anything about the children, just randomly put them in the treatment group and the control group, and that way I can't influence what's going to happen, and I can't, without knowing it, put all the kids with greater potential to change in the treatment group and all the kids with less potential to change in the control group, which is what was happening in the Lovaas program, right? But now people are much more sophisticated. So Tris has done a nice randomized control study, and you can see this is a comprehensive. They're going to try to rehabilitate every skill they can. 2 years, 35 to 40 hours a week, and then, 50-minute trials, 3 to 8. I think you all know about this. Very intensive kinds of treatment.